One of the key issues in quality of healthcare is that in spite of the availability of many evidence-based high-impact interventions that can save lives and alleviate suffering, unfortunately, these are not reaching the patients that need them every time they're needed. And in large part, this is because the processes and systems of care delivery are just not organized in ways that are conducive to doing that. Collaborative improvement bridges that gap and allows us to make those interventions happen every time we need them to. I'm going to use an example to show how collaborative improvement works. The example comes from Niger. The aim of the collaborative was to reduce postpartum hemorrhage, the #1 cause of maternal mortality, which is a global phenomenon, not just a Niger phenomenon. And it was to do that through the implementation of the active management of the third stage of labor, and a simple high-impact intervention that can do that. Now, how does this happen? We form teams in the facilities that are participating. Those teams are made up of providers of care that deliver the service. And then we work with those providers, equipping them with the process and the knowledge and the know-how of how to make the improvements happen. That includes analysis of their existing systems. So they start to look at their care delivery systems, what's happening with them. They collect data related to the outcome of interest. And so one of the things that I want to show is like data. This is data that's collected by health workers. And as you can see, the blue line at the bottom is the implementation of the active management of the third stage of labor. The red line at the top is the proportion of women who have postpartum hemorrhage. Now, they start to analyze this data. They look at how they can bridge things. And this is where they start to use improvement methods, namely, testing changes based on the evidence that's available to see how they can reduce postpartum hemorrhage in this particular case. They use the Plan, Do, Study, Act cycles that we heard about this morning in order to do so. As they were doing this, one of the things they found out is that the oxytocin, which is an essential component of the active management of the third stage of labor, is a thermally unstable drug. It's kept in the fridge. The fridge is usually in these health centers only one fridge, which is locked up in the pharmacy. Deliveries happen at night. The birth attendant who's taking care of the delivery has no time. She's got a newborn on her hands, a woman. There's no time to go and get the pharmacist to do this. They can't buy new fridges. There's just not the resources to do that sort of thing. So they start to come up with creative ways to bridge the gap by making the drug that they need, which is available in the health center, and they know how to administer it, or if they don't, we provide some training as needed to do that. And some of the, and so on, I'm cutting this very short, but basically they come up with very creative solutions. In this particular case, I'll name a couple of solutions that they come up with. One was to pre-fill a syringe with oxytocin, put it on an ice pack whenever a woman comes in, have it ready for administration at the time that it's needed. In other places, they managed to buy coolers, which were much cheaper and were doable. And then they start to look at how does this work? Does this solve the problem? And they work on, they continue to collect their data, look at the results that they're getting. Now, what I'm going to show you in this time series chart is aggregate data for 33 health centers on how they were able to increase compliance with the active management of the third stage of labor and thereby reduce postpartum hemorrhage very significantly. Now, all we need is these are 33 health centers. All we need is one of the health centers, one person to test this, see that it works. What happens is in collaborative improvement, we bring them together at points in time to learn from each other and discuss and share their experiences. And they see that this is happening. They test those same solutions again, and they figure out how it's done. others test other solutions, and they together learn from each other. The learning happens at the learning sessions. It happens when the coaches go to help them because they transfer knowledge between them. And then there's also individual interactions between different health centers, be them through visits or by other communications that take place. Just to make sure that I'm presenting this correctly, this data covers pretty much all of the institutional deliveries in the country, about over 30,000 deliveries per year. If I were to sort of explain how this happens, it would look something like this. You've got a health center, or it could be a community-based arrangement, it could be a hospital. You set up a team of the people who work on this, on the issue of interest. So they represent the different functions involved in the system of care delivery. They plot their data, they're analyzing their systems, they start to look at different changes that they're making in their health center or in their facility. There's many of them in a collaborative setting. You have multiple teams that are trying all to accomplish the same thing. They're using PDSAs to do that. And then they go to learning sessions where they exchange experiences. And then there's a synthesis of what's happening and a sharing of experiences that happens across all of those places. Now, this is one example of many, and oftentimes we get asked questions. So one of the key things that we get asked is this sustainable? And what I'm showing you here is the result of an external evaluation that was done for that project with using a subset of sites. The columns show you the degree of compliance with the active management of the third stage of labor. And as you can see, not only is the data, is it sustained after the end of the collaborative, you can see that there's the end of the collaborative shown on the graph, but also the data between the external collaborative, between the external evaluators and the health workers is consistent. The other question that we often get is this cost effective? And in this particular case, we conducted a cost effectiveness analysis, which showed that the average cost per birth decreased from $35 to $28 per delivery with an incremental cost effectiveness ratio of $147 per DALI averted. This is published in the literature. The other question that we often get asked, is this replicable, is this scalable? This is data that shows 3 subsequent waves of replicating this work in neighboring Mali. This was done by the Niger team without technical assistance from Bethesda. This data is for 329 facilities, accounting for over 17,000 births per year. Again, this whole experience is also documented, published in the literature. The same thinking can be applied to more complicated issues. So for example, here, we're looking at caring for patients with HIV who require antiretroviral therapy. Basically, we're looking at bridging gaps between patients who need treatment and who are on treatment, patients who are started on treatment and retained on treatment, and those that are retained and doing well on treatment. The line in the middle shows the end of the work, and as you can see, the work continues beyond the actual intervention, so there's sustainability involved in this. This same work is now replicated in 2 other regions in Uganda, districts, Mityana and Nakasaki, using a stepped wedged approach in order to see that this is applicable to whether the effect is due to the intervention or some other phenomenon. I want to share one other example. This comes from the country of Georgia in non-communicable diseases. This is data related to non-communicable disease compliance reported by the health workers. This is data for 210 charts per month. And the difference here is that we conducted a controlled evaluation of the to look at the attributable difference related to the intervention. And as you can see, the attributable difference ranged from anywhere from 40 to 91% of the effect that we have seen. The weaknesses here is that it requires a combination of expertise. It requires working at multiple levels in the system. The in-person meetings may interrupt delivery and have a cost associated with them. The strengths is that it addresses key issues in global health. It's adapted to the local context, builds ownership and leadership, cost-effective, and it's robust across multiple areas.
Thank you very much, Rashad, and thank you for addressing many of the measurement criteria that we're trying to understand and evaluate the interventions against. Mike, would you like to go next?